Coming up in this episode, and you sometimes have to coach the patient. They might just close their eyes and they might not really give it a good go. You have to say really tight, 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 tight. And then you ask the patient to smile. And I usually ask the patient just to do a little smile to begin with, because sometimes that's actually more helpful than a big smile, and then a big smile, and then show me your teeth. Hello, and welcome to the next installment of Risfeld Neurology Education, a not-for-profit, free open access project with a philosophical touch, exploring all areas of clinical neurology. I'm Tom Risfeld, your host, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Today I'll be presenting the second part of the cranial nerves examination theory with pearls and pitfalls lecture. The first part dragged on a bit, so I decided to split it into 2 episodes to make it a bit more palatable for everybody. So let's dive into it. But before we do, a legal disclaimer. The content of this episode is for educational purposes only. Okay, moving on now to the 5th and the 7th nerve. So this is the trigeminal and the facial nerve. So the 5th nerve is divided into 3 divisions from a sensory perspective. The ophthalmic, maxillary, and mandibular branches, V1, 2, and 3, respectively. And in order to assess them, you're testing sensation in the forehead, over the maxilla, so over the cheekbones, and then over the mandibular bone, so over the jawbone. Usually I'm just examining light touch. You could examine other sensory modalities as well if you wanted to. You could examine pinprick or temperature, although usually that's not so helpful unless, for example, you're examining for a lateral medullary syndrome and you're looking for dissociative sensory loss, and you might specifically want to know if temperature sensation in the face is impaired or not. But apart from that, it's usually okay just to test light touch in the face, I would argue. And you can just test for neglect at the same time as when you're testing touch to begin with. So you can just touch, you can say, which side of your face am I touching? And then just lightly touch both sides of the patient's face so that they can't see which side you're touching. And if they say, oh, you're touching both sides, then they can feel both sides and they don't have neglect. And that does the trick. And then just do it here and here as well. Then the motor component of the 5th nerve is 2 main muscles as far as we're concerned in our cranial nerve exam, the temporalis and the masseter muscles. So to do that, you just get the patient to clench their jaw like this, and then you look at and palpate the temporalis muscles up here over the temples and the masseter muscles here. And if there's an obvious difference in the strength that you're palpating under your fingers, then that would be abnormal. Or if you can see an obvious asymmetry in the muscle bulk or the facial appearance with the jaw clenching, then that's abnormal. Next is the motor component of the 7th nerve, and that's essentially all or most of the other facial muscles. And so you just get the patient to do various facial expressions. And I ask them to raise both their eyebrows up, and then I ask them to relax their eyebrows and then to scrunch their eyes shut as tight as they can. And you sometimes have to coach the patient. They might just close their eyes and they might not really give it a good go. You have to say really tight, 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 tight. And then you ask the patient to smile. And I usually ask the patient just to do a little smile to begin with, because sometimes that's actually more helpful than a big smile, and then a big smile, and then show me your teeth. So like if you're watching on the video, little smile, big smile, and then showing your teeth like this. And you're really looking for any facial asymmetries. A lot of people then palpate the facial muscles as well, which is a good thing to do. Although for a screening cranial nerve exam, if someone clearly has completely normal facial movements and there's no asymmetries, I'm not sure that it's always completely necessary. But if there's any doubt, or if you're being really thorough, then yes, you should palpate to really physically assess the strength as well, so you can get them to raise their eyebrows up and then try and physically depress the frontalis muscle and see if you can overcome it or not. Get them to really scrunch their eyes shut and then see if you can physically overcome with active eye opening against forced eye closure or not. And then get them to puff out their cheeks and see if you can actively push against the cheek muscles as well. Now, why do we bother doing this? Well, one of the most important things to try and do is, if the patient does have facial weakness, to distinguish an upper motor neuron lesion cause for a facial weakness from a lower motor neuron lesion cause for a facial weakness. And the way that you do that is by assessing whether there is forehead sparing or not. Because with an upper motor neuron lesion, there is forehead sparing. And this is because the facial nerve, so the lower motor neuron in the pons, has bilateral representation from the corticobulbar tracts that are part of the upper motor neuron and then go to the face area in the motor cortex on both sides of the brain. So, suppose that the patient has a stroke or some other form of lesion which is affecting their left precentral gyrus. So, the upper motor neurons with the cell body and the grey matter in the left precentral gyrus, and then the axon going through the white matter tracts and the corticobulbar tracts are not going to be working, and so they're not going to be having any effective function on the right facial nerve nucleus in the pons. However, the contralateral precentral gyrus in the right precentral gyrus will still be intact, and so that will also be feeding onto the right facial nerve nucleus in the pons. So the right side of the face in the forehead will still be functioning, even though there's a lesion in the left precentral gyrus in the facial area. However, the same is not true for the mid-face and the lower face. So the right mid-face and the right lower face will be weak, but there will be sparing of the forehead. So that is an upper motor neuron pattern of facial weakness. Conversely, if there's a lower motor neuron lesion, so affecting the actual facial nerve itself or the nucleus of the facial nerve in the pons, but it's still a lower motor neuron lesion because it's still knocking out the lower motor neuron, then it doesn't matter what's happening upstream of that. It doesn't matter if the left and or the right corticobulbar tracts and the left and or the right precentral gyri are working perfectly, because downstream of that, the lower motor neuron isn't working. And so both the upper part of the face, the forehead, and the middle and the lower part of the face will not be working. So you have facial weakness that affects the whole face, a complete facial palsy. You can, in reality, get some really nasty big strokes that do cause full facial weakness. This really only occurs for one of two reasons. Either the stroke, whether it be ischemic or hemorrhagic, is actually affecting the brainstem and it's therefore knocking out the facial nucleus in the pons, and it's therefore actually causing a lower motor neuron facial weakness. Or it's an anterior circulation stroke, whether that be ischemic or hemorrhagic, and it's affecting the precentral gyrus or the white matter structures beneath it. But it's a large stroke, and so it's actually also affecting the fibers which are contralateral and decussating, as well as just the ipsilateral fibers. So if you have a large anterior circulation ischemic or hemorrhagic stroke, which is so large that it's also affecting the corpus callosum and the supplementary motor areas, then you can affect both the corticobulbar tracts, which are destined to remain ipsilateral, and those which are destined to decussate and become contralateral. So you can have a big nasty stroke that does cause complete facial weakness, including forehead involvement, even if it is an anterior circulation stroke. And when we get up to our future episode on the NIHSS, the NIS assessment, in terms of performing a hyperacute stroke assessment, you'll learn that one of the scores for facial weakness includes complete facial weakness, and that can be a little bit confusing because you might think, why would a stroke ever cause complete facial weakness? But it can. However, it should be pretty obvious in that instance if a patient comes in with sudden onset complete facial weakness because they've had a massive stroke, then they're not just going to have the appearance of an isolated facial palsy, they're going to have obvious other deficits as well, such as a hemiparesis or hemiplegia or hemianesthesia and reduced level of consciousness and such. So it should be pretty obvious in that instance, and it shouldn't lead to any confusion. Conversely, Sometimes it's not so obvious, especially in an early evolving lower motor neuron facial weakness, and that's a common cause for a stroke mimic at a hyperacute stroke call, because sometimes the forehead involvement in a lower motor neuron facial palsy isn't that obvious to begin with, and it can become a bit more obvious with time, or it might just be a partial palsy, and so it might never be that obvious. So one thing you can do to try and help distinguish that is by getting the patient to really try and bring their eyes shut as tight as they can. And you might notice that the eyelashes are not quite as close together on the side with the lower motor neuron facial palsy, because the upper eyelashes are not moving properly, and so there's just a bit of asymmetry in the way that the eyelashes look. So that's a subtle way that you can try and tell a difference. Another way that you can try and tell a difference is by assessing some of the other functions of the facial nerve, which is the sensory function, which is accessible, which is the anterior two-thirds taste of the tongue. So that's occasionally also useful in distinguishing an upper from a lower motor neuron facial weakness in tricky cases. Then there are two reflex arcs which are relevant to the fifth and the seventh nerve, which are sometimes useful. Firstly, there's the jaw jerk. Now, this is the only reflex arc in the cranial nerves which the afferent and efferent limb are both mediated by the same nerve. So both the afferent and the efferent limb are mediated by the trigeminal nerve. Usually, so in a normal patient, the jaw jerk response should be absent or minimally present, whereas it's abnormal if there's an exaggerated or a very marked, obvious jaw jerk present, and so the mouth closes shut quickly. So what that means is the mouth already has to be a little bit open before you hit the mouth. There's no point having the mouth closed shut before you even elicit the reflex, because it's already closed. So it has to just be like loosely a little bit ajar. And you're not going to strike the mentalis, the chin area, directly with your tendon hammer. That wouldn't be very kind. So you put your thumb over the chin and then you tap your thumb with the tendon hammer like this. And if there's an upper motor neuron lesion present, then you'll get this exaggerated brisk closure of the jaw. So that can be useful in the neuromuscular context. Similarly, the corneal reflex can be examined. This has the afferent limb mediated by the fifth nerve and the efferent limb mediated by the seventh nerve. So what happens normally in the corneal reflex response? Well, you touch the cornea on one eye and then you get a bilateral blink response. So unilateral stimulation results in a bilateral response. Conversely, if there's an abnormal response, depending on which arc is affected, you can figure out where the lesion is. So if you stimulated the left cornea and neither eye blinks, then the problem has to be with the afferent limb. So it's with the left fifth nerve. Conversely, if you stimulate the left cornea and the left eye blinks, but not the right eye, then you know that the problem is with the efferent limb of the right eye. So the problem is with the right facial nerve as opposed to it being a left trigeminal nerve problem. And then, of course, you can apply the inverse of what I just said for the other eye. There's a few pearls and pitfalls here. The main one is often I see people try and examine a corneal reflex and they don't actually stimulate the cornea, they stimulate the sclera off to the side instead. So it's not the scleral reflex, it's the corneal reflex. So you can't just touch the white of the eye, it has to actually be the clear bit which is anterior to the pupil, the cornea, that you have to touch. And obviously you're using something very soft and sterile, like a little wisp of sterile cotton wool when you're examining the corneal reflex. The other thing to be mindful of is you should try and avoid coming in directly in front of the patient to undermine the reliability of your test by causing them to blink just by the anticipation that you're about to touch their eye. So you should try and get them to look in a direction that you're not coming from and stand off to the side and be a bit sneaky and come in from the side so that the patient doesn't know when you're about to touch their eye, so that they can't anticipate it and blink in anticipation or as a protective maneuver. so that you kind of catch them by surprise when you do touch their cornea so that they actually blink in response to the sensory stimulus that you have provided, as opposed to just an anticipatory blink. So that's the other important point there. So now we're up to the eighth nerve, which is the vestibulocochlear nerve, or otherwise known as the auditory nerve. So firstly, you examine gross hearing, and that can be done in one of two ways. You can either just rustle your fingers next to the ear, and that's actually my preferred method. I don't really think that it has disadvantages compared with the next method that I'm about to tell you, and it's just easier and faster to do. And you can also test for auditory neglect by doing so, because you can put both hands next to both ears and ask the patient, which hand am I rustling? And just ask them to tell you, and you do the left and then the right and then both, and you see if they get the both question correct as well. It's important not to rustle your fingers too loud so that the right hand could be heard on the left. So it's just a very, very gentle little rustle. And if you test it on yourself right now, if you put your hand right next to your ear and then just do a very, 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 very gentle rustle, you can hear it very clearly. So it just has to be very gentle. The alternative way you can do it, which I see a lot of people doing, which is okay as well, is you deliberately make a rustling noise in one ear to deafen that ear, to occlude other sounds getting into that ear. And then in the other ear, you put your lips right next to the patient's ear and you whisper something like a number, and you ask them to tell you what the number is. I don't really see how that has a particular advantage over the first method, but you can do it either way if you want to. I do think it has some disadvantages though. Firstly, you can't really test for neglect in that way. It's slower, but probably most importantly of all, lots of people just don't whisper quietly enough. Like, I'll be standing at the other end of the room watching someone examine this, and they will whisper, quote unquote whisper, and I'll be able to hear it from the other end of the room. And I'm 5 times the distance from the examiner as the patient's other ear is from the examiner. So if you are going to use the whispering method, you really, really need to whisper really, really softly. So the faintest whisper you can possibly do should be loud enough. Now, Weber's and Rennie's test. Weber's and Rennie's test really isn't a routine part of my cranial nerve examination, but if there's a problem with hearing identified, or if there's a specific concern about the function of the vestibulocochlear nerve, or specifically the cochlear component of the vestibulocochlear nerve, then it should be examined. Ideally, you should use a 512 hertz tuning fork if you have one. So one of these little ones. If you don't have one, then a 256 hertz tuning fork can be used, although that's less optimal. Whereas a 128 hertz tuning fork, so the bigger ones that are used for testing vibration in the arms and the legs, are really not adequate for assessing Weber's and Rene's test, because it just causes bony vibrations as opposed to testing the hearing apparatus. I actually think that Weber's and Rene's tests are pretty complicated to understand. Ironically, given that I learnt this in first year medical school about 15 or more years ago, and the number of times it's come up. And it was actually part of my OSCE examination in my second year medical school exam. And I did get it right at the time. And it seems to be something that they love examining medical students on and physician trainees on, even though it doesn't come up in clinical practice that often, but it's an easy thing to examine. It's actually not that straightforward, but hopefully I can walk you through it and make it relatively straightforward. So there's two ways to approach it. You can do Weber's test first, or you can do Rene's test first. I was taught to begin with Weber's test and then proceed to Rene's test. I've seen some other sources of information recommend doing the opposite. Ultimately, you end up needing to do both anyway, so it probably doesn't matter a great deal one way or the other, but I'm going to go with the way that I've been taught, which is to begin with Weber's test first. Weber's is the one, in terms of remembering which one's which, just remember that Weber's is the one in the middle, so you're putting the base of the tuning fork partway in between the vertex and the middle of the frontal bone in the middle of the head here. And then Rennie's test is the other one, which is the one just behind the ear on each side. Annoyingly, I had a really good way of remembering which one was which, apart from the fact that the mnemonic was the wrong way around. So I'm not going to tell you because it's just going to confuse you. And I actually told one of my colleagues and he berated me for telling him because he said he's going to get it wrong now for the rest of his life because I told him this great mnemonic, which is incorrect. So I'll fight the temptation to tell you my awesome but incorrect mnemonic. So you'll have to come up with your own for remembering which one is which. So how do you do Weber's test? So you put the tuning fork in the middle of the head here, and then you ask the patient to say, where is it that you're hearing the noise, the buzzing, the ringing, the vibration? Where are you hearing it? Where are you feeling it in your head? And the normal response is for it to be heard, to be experienced equally, symmetrically. If it's abnormal, then what that tells you is that it's either abnormal on the louder side if the problem is conductive deafness, or is abnormal on the softer side if the problem is sensorineural deafness. But at this stage of the assessment, you don't know which is which. So for example, if you start with Weber's test and the patient says, oh, it's much louder in my right ear, then that means that the patient could either have conductive deafness in the right ear, or they could have sensorineural deafness in the left ear, assuming that the problem that they have is unilateral and only one of the two problems. It's much more complicated if it's a bilateral pathology or if it's a mixed pathology of conductive and sensorineural deafness. Next, you move on to Rennie's test, which is the one where you, again, get the tuning fork to start buzzing, and then you place it behind the ear on the mastoid process. What you then do is you ask the patient to tell you when the sound stops. And when the sound stops, you then move the arms of the fork right in front of and lateral to the pinna, the auricle. And you ask the patient if that sound resumes. And it's normal that it does resume. And the reason for this is air conduction in normal circumstances is better than bone conduction. I also find this counterintuitive because we know that in non-physiological systems, sound travels much better and faster in solids than in liquids than in gases. So for example, if you're communicating via Morse code and you're tapping on a wall, that can be heard by someone kilometers and kilometers away by listening to the wall and the taps. And aquatic animals can communicate with each other underwater for kilometers and kilometers away by transmitting sound through a liquid medium, whereas sound doesn't travel nearly as efficiently or quickly through gases, such as air. However, humans are not solid walls and we're not whales. We're humans and we breathe air and we live in air. So our ears and our hearing organs have evolved to work differently, and our hearing apparatus is dependent on our tympanic membrane and the bones in our hearing apparatus, and it needs vibrating air to work, which is a gas. So it requires the transmission of sound through air to make the tympanic membrane vibrate, to activate the hearing apparatus, to then activate the cochlea and then the eighth nerve. So just remember that air conduction for human ears is supposed to be better than bone conduction. So the normal response in Rennie's test is for when you can't hear the buzzing over the bone and then you put it over the ear in the air, the patient should then be able to hear the buzzing again. Conversely, it's abnormal if the experience doesn't return. And so that then tells you that there's a problem in that ear. But herein lies the rub. Sensorineural pathology can reduce air conduction and bone conduction equally. Therefore, air conduction can still exceed bone conduction in the context of sensorineural pathology, so Rennie's can still be normal in this context. Conversely, if Rennie's is abnormal, that's because the air conduction does not exceed bone conduction. So when you move the tuning fork from the mastoid process to just lateral to the pinna, the patient does not hear the sound again. You can then conclude that that ear is abnormal with the abnormal Rinne's test, and you know that it's a conductive problem in that ear, but it doesn't tell you anything about the presence or absence of sensorineural hearing problems. That's why you need to combine Rinne's test with Weber's test. Now, hopefully I haven't confused you too much. This is going to be a summary of everything that I've just said in regards to Weber's and Rinne's test. So in terms of interpreting the tests, it's actually, I think, a lot easier to work backwards from the diagnosis. So I've just written up a table and it's got 5 cells in the table. So the 5 cells are right ear conductive deafness, left ear conductive deafness, right ear sensorineural deafness, left ear sensorineural deafness, and then both ears normal. So in both ears normal, Weber's will be normal, so it will be equally and symmetrically loud in both ears. And Rinne's test will also be normal bilaterally, so air conduction will be better than bone conduction bilaterally. Then in right ear conductive deafness, Weber's will be abnormal and it will be louder on the right side. Then Rinne's test will be abnormal on the right side, meaning air conduction will not be better than bone conduction on the right side. And the way that I make sense of that is there's a conductive problem. So maybe there's lots of wax in the ear or there's a tympanic membrane perforation. So the vibration of air just isn't getting through and it's just not stimulating the cochlea and it's not stimulating the vestibulocochlear nerve. So it's not making its way to the primary auditory cortex. So you're not hearing anything. So that's why the air conduction is not working as it should. So the air conduction is not better than the bone conduction because the vibrating air just isn't working in terms of activating the neurologic components of the hearing pathway. Conversely, let's think about right ear sensorineural deafness. So in that instance, Weber's test will be abnormal, but it will be heard louder on the left side. And then Rinne's test will be normal on the right ear. So that will mean that air conduction is better than bone conduction on the right ear. It will also be normal in the other ear that I didn't mention. So the way that I make sense of that is in sensorineural deafness, the problem is not the tympanic membrane and the bones in the hearing apparatus. So the air conduction is still better than the bone conduction as would normally be expected because we're humans and we do better hearing with vibrating air than we do with vibrating solids and bone. The problem is with the neural component of the hearing arc. So it's a problem with, say, the cochlea or the vestibulocochlear nerve or something upstream of that process. So that's why when you're doing Weber's test, it's heard louder on the normal side because that side is still got the whole hearing arc intact, whereas it's heard less well, softer, on the abnormal side. So I hope that has made sense. And then, of course, for left ear conductive deafness and left ear sensorineural deafness, you can just apply everything that I just said to the right ear, but swap around the left and the right. Now, this simple table, which I've just talked you through, works for a patient with normal hearing, and it works for a patient who has a unilateral problem, which is either conductive or sensorineural deafness. It does not work in more complex cases where there are bilateral pathologies and or where there is mixed conductive and sensorineural deafness. So if someone has conductive deafness in the left ear and sensorineural deafness in the right ear, or they have mixed conductive and sensorineural deafness in the left ear, or they have mixed conductive and sensorineural deafness in the right ear and conductive deafness in the left ear, the table I work you through is too simple and it does not accommodate those more complex scenarios. However, I initially tried to develop a flowchart working forwards rather than backwards, but there's too many combinations to work through. So there's 3 different combinations that Weber's test can have, because it can either be normal or it can localize louder to the left ear or to the right ear. And then there's 2 states that René's test can be in the left ear, and there's 2 states that René's test can be in the right ear. So that then results in 12 different combinations, and only 5 of those 12 combinations are accounted for in the table that I just talked you through. Or if it was even more severe to the extent that the patient was just completely deaf bilaterally, then plausibly you could have Weber's test not being heard in either ear. Or if the hearing apparatus was just completely absent, or the more upstream components of the hearing apparatus were completely absent on one side, then feasibly you could have René's test, which is not heard on the bone or in front of the ear. So that would then increase the combinations from 3 times 2 times 2 to 4 times 3 times 3, which would be 36 different combinations. So hopefully you can see why I've worked backwards rather than forwards. So if the patient does have bilateral problems or mixed problems, that's going to be very, very difficult to clinically sort out reliably using Weber's and René's tests. And honestly, the patient just needs formal audiometry at that point. Also, don't forget your trusty otoscope. It always helps to actually look in the ear if the patient has conductive deafness and make sure that they don't just have an ear full of wax or a tympanic membrane perforation or something like this, because that's a very easy and quick thing to do. Now, of course, the second part of the vestibulocochlear nerve is the vestibular component and the whole vestibular system, and that comprises the Dix-Hallpike examination and the Hintz examination. But I'm going to be discussing that in its own dedicated episode on the vestibular examination, because that's only applied in specific clinical circumstances. Next up, we have the 9th, 10th, and 12th nerves, so the glossopharyngeal, vagus, and hypoglossal nerves. Firstly, you look at uvula and palate positions and movements, so that's the 9th and the 10th nerve, and they both control both of these, so they're examined together. So the important thing to know here is that the uvula and the palate deviate away from the side of the weak muscles, or in other words, they get pulled towards the side of the strong muscles. So again, they deviate away from the side of the weak muscles. However, one thing that confused me for a while until I got my head around this is that it's the side of the muscles that we're referring to. Whereas if the lesion is not in the muscle, but the lesion is a neuropathic lesion, then the side of the lesion still depends somewhat on whether it's an upper motor neuron lesion or a lower motor neuron lesion. Because, as we know, the corticobulbar fibers decussate. But it's a bit complicated in the context of the cranial nerves, because a lot of the cranial nerves have varying degrees of bilateral innervation from the upper motor neuron, as we already discussed at length in regards to the facial nerve in the forehead compared with the mid and the lower face. So, in the case of the 9th nerve, there is an upper motor neuron supply which is bilateral. So it would be uncommon for an upper motor neuron lesion to cause significant weakness of the muscles by virtue of it affecting the corticobulbar fibers destined for the 9th nerve. However, the 10th nerve, whilst also having bilateral upper motor neuron supply, does have some slight contralateral dominance. So what that means is a upper motor neuron lesion affecting the fibers destined for the 10th nerve nucleus can still cause some degree of weakness of the contralateral muscles. So a left-sided cerebral lesion could cause some weakness of the right-sided muscles, which could therefore cause the uvula and palate to deviate away from the side of the weak muscles on the right, so it could cause them to deviate to the left. Now, moving on to tongue positions and movements, they're controlled by the 12th nerve, the hypoglossal nerve, and the direction they move in the context of pathology is the opposite to the 9th and the 10th nerve. So the tongue deviates towards the side of the weak muscles, or in other words, it gets pushed away from the side with the strong muscles. So to say it again, the tongue, it deviates towards the side of the weak muscles. Although again, if it's not a myopathy of the genioglossus, but it's a neuropathy of the upper or lower motor neuron, then that can be relevant in this case. And furthermore, the upper motor neuron supply of the 12th nerve is predominantly contralateral, so the bilateral component is minimal. So what that means is if the left side of the genioglossus muscle itself is weak, or if the left hypoglossal nerve is weak, causing weakness of the left side of the genioglossus muscle, then the tongue will deviate towards the weak side, towards the left side. But if there's a left-sided cerebral lesion, that will then cause reduced function of the right hypoglossal nerve. So the tongue will then deviate towards the right side, which is the side of the weak muscles on the right. So I hope that's cleared up some confusion, because that's confused me for a long time before I finally sussed that out. Then you're going to be looking at dysarthria and dysphagia as well. And that's predominantly looking at your bulbar muscles, which is referring to muscles supplied by the cranial nerves originating from the medulla. And in this case, we're referring to the 9th, 10th, and 12th nerves, with a partial contribution from the muscles of facial expression involved in speaking and swallowing. So some of the muscles innervated by the 5th and the 7th nerve, but predominantly the 9th, 10th, and 12th nerves. And importantly, dysarthria can be in a bulbar or a pseudobulbar pattern, but we'll discuss that more in some of our neurodegenerative episodes. Then I don't usually examine these, but occasionally it is relevant. So firstly, there's a gag reflex. And again, this has an afferent limb and an efferent limb. The afferent limb is the 9th nerve and the efferent limb is the 10th nerve. And one thing you may have picked up on now that I've finished talking about all these reflex arcs in the cranial nerves is that, with the exception of the 5th nerve with the jaw jerk, where both limbs are with one nerve, with all the other reflex arcs where the afferent and the efferent limb are mediated by one nerve and then a different nerve, it's always the lower number, which is the afferent limb, and the higher number, which is the efferent limb. So in the context of the gag reflex, the lower number, the 9th nerve, is the afferent limb, and the higher number, the 10th nerve, is the efferent limb. And then finally, I can't say that this has ever been clinically relevant, but the sensation to the posterior 1/3 of the tongue for both somatic sensation and special taste sensation is mediated by the 9th nerve. So that is something which is examinable, but I can't say that's ever been helpful in my own clinical practice. So last but not least is the 11th nerve, the spinal accessory nerve, or just the accessory nerve. So this is quick and easy to examine. You examine shoulder shrug strength bilaterally, so you're assessing the strength of the trapezius muscle on both sides, and that can be done at the same time. So you just get the patient to do a nice big shrug, bring their shoulders up towards their earlobes, and then push down really hard and make sure that you can't overcome it. And then you're testing head rotation strength, which is testing the power of the SCM, the sternocleidomastoid muscle. The one trap not to fall into here, which most of you may know, is that the left sternocleidomastoid muscle actually rotates the head to the right and vice versa. So don't fall into the trap of thinking otherwise. And the reason for this is just biomechanical. It's based on the anatomical origin and insertion points of the muscle. And what happens when one of the SCM contracts is that it effectively pulls the mastoid process antero-inferiorly. So if you're watching on video, you can see, suppose I have my left SCM here, it's attached to the mastoid process here on my left, and when it contracts, it's pulling my head antero-inferiorly, so it's pulling it like this, effectively pulling the mastoid process closer to the clavicle and the sternum on the same side, and it causes the head to turn in the opposite direction, in case you were curious about that. So hopefully you've learnt some ways as to how to do the cranial nerve examination well, how not to do it not well, and how to remember it and how to link it to relevant pathology that you may be encountering in your clinical practice, and also identifying the components of the cranial nerve examination which are really important all of the time. So that's the text which has been in black the whole way through. The components which are sometimes important, and that's the text which has been in orange. And the components which have been in grey, which are the components which are not helpful a lot of the time, but can be helpful in select circumstances. And I want to conclude by saying that there is a way to pragmatically do a really quick full cranial nerve assessment in 1 to 2 minutes in most cases, whilst omitting the grey text rarely performed components. So, to do this, second nerve, acuity fields, in some instances, fundoscopy and colour vision. Then second and third nerve, pupillary light reflexes, and ptosis. Then third, fourth, and sixth nerve, extraocular movements, and sometimes an internuclear ophthalmoplegia test and saccadic testing. Then the fifth and seventh nerve together, testing for facial, sensory, and motor function. Next, the eighth nerve, testing hearing, and then sometimes testing vestibular assessment in the clinical context. Then the ninth, 10th, and 12th nerve, looking for the uvula and palate positions and movements, tongue positions and movements, and assessing for dysarthria and dysphagia. And lastly, the 11th nerve, testing shoulder shrug and head rotation strength. And this really can be done in about 1.5 minutes. And I'll do a second video doing a practical demonstration proving how that can be done. And with practice, you want to get to the point where you can just do this on autopilot. So you're not trying to think, oh, what's the next step? You should have just done it so many times that it's literally on autopilot. So you're actually just focusing on interpreting the signs that are coming to you and making sense of them so that you can localize the pathology rather than trying to remember what the next step is. Don't do this in your examinations, but pragmatically, I deliberately do it a little bit out of order because it's faster. So I do the bits that require equipment with a torch at the end. So I deliberately do it in the order I described, except that when I get to the end and I'm looking in the back of the palette, I need a torch to do that. So I get my pen torch out or my light on my smartphone, look in the back of the palette, and then I should have said also, sometimes you may need a tongue depressor if the patient really can't open their mouth properly and you can't see their palate, you may need a tongue depressor. So I've got my torch out and then I'll go back to the pupillary reflexes right at the end. Don't do this in examinations because your examiner will totally freak out and think that you've forgotten it, and that is not the mindset you want your examiner to be in. But in pragmatic clinical practice, it is faster to do it that way. And then I just do fundoscopy at the end because I find it's just the most efficient that way. And that's it for the theory behind the examination of the cranial nerves. Thanks for sticking with me, and I really hope that you have learned a thing or two about not just what the cranial nerve examination is and what the components are, but how to do it well, how not to do it not well, why it's important, and what we're thinking about when we're doing the cranial nerve examination. I've tried to link in the ways in which the different components of the cranial nerve examination are clinically relevant and what some of the key pathologies are to look out for. And I've tried to link those connections to help you remember the components of the cranial nerve examination and to remember how to interpret it and what the different pathologies are that you may be encountering in your clinical practice. So if this has been helpful for you, please do like, comment, and subscribe. Tell your friends and colleagues about the show if you've been enjoying it. Visit us at rneurologyeducation.org, that's R for the letter R, for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms at rneurologyeducation. Also, please email us on contact@rneurologyeducation.org with any questions that you may have, or to subscribe for updates when new content is released. From cortex to curiosity, this has been Restored Neurology Education. Until next time, keep calm and synapse on.